Welcome everyone. So welcome to this introductory webinar on the PRES Level 3 examination, which for most of you, if not all of you, is the final requirement for the Irish Medical Council to complete your sort of registration journey to become licensed medical practitioners in the Republic of Ireland. The purpose of today, the next couple of hours, is for me just to sit here opposite you guys and talk to you about the exam, only about PRES Level 3. So I'm going to just try and keep it very specific to the actual exam, give you a comprehensive overview of everything that you're required to know before you actually go into the exam. So in terms of what things are tested, what to expect on the actual exam day, how best to prepare for the exam day, and then I'll touch upon obviously our course that we'll be running more towards the end, and I'll leave the final part, the last sort of 20 or 30 minutes, to answer any questions that you may have. You can talk to me and ask me anything you wish. And I have a wealth of knowledge for this exam. I've been doing it for a very long time now. I've been teaching PRES3 since 2016, and I've been preparing students for every single exam for PRES3 since September 2016. So I've got a wealth of information and a wealth of knowledge to give you. Although I haven't actually sat the exam myself, I consider myself somewhat an expert in this exam now because sheerly because of the length of time that I have been conducting classes and lectures for this exam. Just a bit of background about myself. So obviously, for those that have had the, for those of you that know me, my name is Dr. Karam Singh. I work actually in the UK, so I'm not based in Ireland, but I work in the UK, not very far from Dublin, and I work as a GP. So my medical pathway, it's a little bit different in the UK as it is in Republic of Ireland, but I did my what would we call them foundation year, so foundation year 1 and foundation year 2 in the UK, and then I decided to take on the medical route. So my aim was actually to become a medical consultant. So I did my core medical training initially. When I was doing it, it was only 2 years. In the UK, they've now actually changed it to 3 years. So I did core medical training year 1 and year 2, and my dream was to become a geriatrician, an old age people's doctor, and to deal with palliative care and end of life care. So I became a medical registrar. I did a couple of years of geriatrics, and then I decided, because my teaching was taking up so much of my time, I was finding it very difficult to balance out medical training and also the educational side of things as well. So I decided to take a bit of a different route. So I took general practice. So I trained to be a GP. It took me 2 years. Training here is 3 years because of my previous medical experience. They shortened my training to only 2 years, which was good. And then only a couple of years ago, I completed my training as a GP, and how I work now is more of a portfolio GP, which means that half of my time is spent doing clinical work, so obviously day-to-day general practice, and the other half of my time is in universities, lecturing on various different subjects, and obviously teaching for Plabcoach. That I've been doing. Actually, I've been teaching Plabcoach even before I started my medical career as a doctor. I started it 6 months before. I had a great passion in teaching, and I started it a few months before actually becoming an FY1, and I've just carried it on ever since. And PRES3 was one of those exams. As I said, I've not done the exam before myself, although I've been to Ireland over 20, 30 times now, but I've never had the fortune to sit this exam myself. But when I was teaching PLAB 2, which is the UK equivalent to PRES Level 3, I had an Argentinian girl who came to my course in the UK, and that was in the early half of 2016. And she said to me that we have this exam in Ireland called PRES3, and I knew nothing about it, absolutely nothing about it. And she said, "Why don't you come over to Dublin? I have a group of students who want to learn OSCEs for." I said, "Okay, fine." So I had a read about PRES3. I went through some of the old past papers that were there, and the information was very scattered. There was no one else doing it at the time. So I thought, okay, this is perhaps something that I can get into. Um, so my very first course was in September 2016, and that was in Dublin, and I taught a small group of students. Basically, it wasn't very specific to PRES3. It was more OSCE training. Um, but then, obviously, as more and more candidates went through the exam, I became a little bit more knowledgeable about what the requirements were for PRES3, according to the Irish Medical Council, and that was it. Then, I made it into a proper course for PRES3. So, as I say, I consider myself somewhat. I don't want to use the term expert, but very knowledgeable in particularly in this exam. This is not the only exam I teach. I teach many different exams. But this exam, I am confident in the information that I deliver because I've been doing it for such a length of time, and the success of previous candidates has shown that through the courses that I've been conducting. So, without further ado, I'm going to kick things off and give you a comprehensive overview of the PRES Level 3 exam. So, what is the actual exam? It is an OSCE, but it's an OSCE with a bit of a twist because they add a second part to the exam, which not many international exams around the world do this. So they've got a second part of the exam, which is the data interpretation, which I'm going to talk to you about in great detail, but just giving you a little bit of an overall format of how the exam actually is. So you've got two parts to the exam. You've got the OSCE and you've got the data interpretation. Now, with the OSCE, there are essentially two parts to that. You've got the communication aspect of it, which encompasses both history taking and you've got the communication skills as well. And you've got your clinical skills and practical skills. So that's your OSCE, and we'll talk about this in much greater detail as I move forward with the webinar. And you've got the data interpretation as well, which the name suggests exactly what this part of the exam tests. It's interpreting data that the average junior doctor in working in an Irish hospital is expected to be able to interpret. For example, ECGs, chest X-rays, arterial blood gases, common clinical scenarios, and more obscure things like growth charts and drug calculations and prescribing skills. So there's lots of things that data interpretation will test, and we'll talk about that in more detail when I actually come onto that section. Now, the disciplines that this exam tests is quite varied compared to other international medical exams. Fortunately or unfortunately, depending on who you are and how you look at this, every single specialty is tested in PRES3. Now, there are some that are more common than others, but I would say that in most exams that I have seen, there has been some mix of these disciplines that have been tested in the actual exam. From obs and gynae, pediatrics, psychiatry certainly comes in almost every single exam. General surgery, general medicine, and general practice. There is a clever mix of all of these disciplines. Not so much for the clinical skills, because obviously clinical and practical skills are, there are a number of skills that you need to know for the exam. These disciplines are more geared towards the communication and history side of things, where you have to communicate a diagnosis, an investigation, a management plan in one of these disciplines. And we'll talk about obviously the specifics of these during the actual course itself, but it's important to know that every single discipline is tested in the actual exam. So none of them are, you may not get all of them. So for example, pediatrics might not come in your exam, but it is important to get yourself prepared for all of these disciplines. Now, I'm going to come on to marking a little bit later towards the end of this webinar, but there are a criteria that the examiners will be looking in terms of when they actually mark you. And these criteria are based on the domains of good medical practice, okay, in Ireland. And there are essentially 8 of those domains that you must be familiar with. And and I'm going to talk about each one of these individually with you. So patient safety and quality of patient care. Obviously, this is one of the forefronts of any regulatory body, that patient safety and quality of care is maintained to the highest degree possible. Your station itself, and I'll talk to you about the actual stations and the format of each station. Your stations are only 7 minutes long. So there's only so much information that you can actually show within that 7 minute period. Okay? Within those 7 minutes. But what you have to show, depending on the task that's been given to you, is that you have maintained patient safety throughout those 7 minutes. Whether you're dealing with a clinical examination, whether you're dealing with a clinical skill, basic life support, history taking. For example, when you're taking a history, are you excluding all the relevant red flags in that history to ensure that you are dealing with that patient safely, coming up with a diagnosis, relevant investigations, and a sensible management plan? Okay. And the quality of care. So when it comes on to the care that you provide that patient, is it best medical practice according to the standards that are expected in Irish hospitals and GP surgeries? So very important, patient safety and the quality of care that is provided to patients. Relating to patients is something that you will be marked on in absolutely every station that you go into. The rapport that you build with the patient right from the introduction, when you introduce yourself as a doctor from whatever department that you're in, by your name, by your grade, all the way through, are you building a trustful, professional, mutual relationship between yourself and the patient sitting opposite you? So relating to patients is going to be a big part of the marking criteria for almost all stations. Okay. This also encompasses things like confidentiality, being honest, and being accountable. There are challenging communications that show up almost every year in your exam that deal with medical negligence, where some form of mistake has happened and you are the one in hospital who has to talk to the patient about an error that's occurred or some form of a mistake that's happened, and you have to be open and honest and accountable for those mistakes, and then obviously talk to the patients about how you're going to rectify those mistakes and how you're going to ensure that they never happen again in the future. Okay? So relating to patients is a very important domain of good medical practice that they will be marking you on, or at least critiquing you on as you proceed through your station and as you proceed through your exam. The third domain is communication and interpersonal skills. Interpersonal skills is very similar to relating to the patient itself, but communication skills, again, is a critical part of any OSCE, not just the PRES level 3. Most of you, if not all of you, have come from outside of the Republic of Ireland or outside of the UK. And English may not be your first language. It may be your first language for a lot of you, but for some of you, it may not necessarily be your first language. So when you're taking a history, when you're communicating bad news or dealing with an angry patient or an angry relative, whatever it may be that requires you to talk to a patient, can you communicate to an effective enough level that the patient understands everything that is said to them during your 6 or 7 minutes? And is the examiner happy with the level of your communication ability as well during the time that they're marking or that they're examining you on? So communication and interpersonal skills, obviously I'm going to go through this in a lot of detail during the actual course itself, how best to communicate, how to build that interpersonal connection with the patient to be able to get the best out of the 7 minutes and to maximize the number of marks that you receive, particularly from the communication skills stations. Now, communication skills are not just tested within the 6 communication skills OSCEs. They are also tested in the clinical skills and the clinical examinations. Because as you examine a patient, you're still communicating to them. You're telling them exactly what you're doing. And as you're examining different parts of, for example, a cardiovascular system, as you move from the end of the bed and you examine them in a systematic approach, you still have to explain that to the patient in very clear um, layman's terms so that they're understanding, and that the consent that they give you for the examination that you need to do on them is an informed consent. So communication is across the board. It's for all 12 of your stations. You need to communicate effectively. So it's a big part of your exam. Collaboration and teamwork, again, is an important part because you're not just there managing the patient in isolation. Even when you work as a GP, you may be the only person that they see during that consultation. They may not necessarily see anyone else before or after you. But even as a general practitioner, or for example, if you're working in hospital, you're never working alone. You may need to communicate with other team members, other allied healthcare professionals, and you need to know how to collaborate and work effectively in a team with those patients to be able to optimize patient care. So there are some stations, if not all stations, where you'll have to talk to the examiner. Now, the examiner is your senior. Okay, he's your consultant or your registrar or your general practitioner. He's your senior that you must talk about the investigations that you want to do, about the diagnosis or the differential diagnosis that you've come up with, and the management plan that you've got for the patient. So you're collaborating with senior members of staff, and that senior member will always be the examiner. In almost every single station, the examiner will have some questions for you. There may be some stations where you need to review a sick patient. Now, this is very common in your exam, the ABCDE station, or the acutely unwell patient, where you need to examine them, come up with a cause for their deterioration, and then effectively hand that information over to a colleague to see if there's anything else that they need to do that may have been missed by you in your initial assessment. So collaboration and teamwork, it may not necessarily be tested in all stations, but it is certainly an important part of your exam, especially for those patients who you'll have to assess, and you need to escalate that to a more senior member of staff, okay, which is usually your examiner. The most difficult part of the OSCE is the management part. The one that I see people scoring the lowest on is the management. A lot of you come from different countries, and the management or the best practice in your country may be different to that of the UK or different to that of Ireland. And you have to ensure that you are up to date with the guidelines that are required to work safely and effectively within this healthcare system. And when I mean this, I mean the Irish healthcare system. Okay? You have to make sure that you're familiar with most of the guidance. And there's an abundance of guidelines that you can read, and guidelines are often never ending. But obviously, during the course, my role for you will be to give you the management of common chronic and acute medical illnesses that will help you navigate through the exam quite easily when it comes to the management part of things. Okay, so management is a big part of almost every station, and it's something that I will talk to you about in great detail when we actually do the course, when we talk about specific scenarios that are tested, and how to effectively manage those scenarios. Scholarship is about continued learning. Okay, about continued learning, understanding that medicine doesn't stop because you become a doctor or you've graduated from medical school. I may have a wealth of clinical knowledge, I may have a wealth of clinical experience, but I don't know everything. There are some fields that if you put me into, I would be completely lost. And that just shows the breadth and the amount of clinical knowledge that is out there in medicine. It's a forever learning process. Now, I never ever stop learning. Never. From the moment I finished medical school up until now, I use every day when I communicate with my colleagues, when I see my patients, as a learning opportunity. And that's a domain of good medical practice that is expected of a doctor, that they understand that, again, fortunately or unfortunately, it's very different to most other areas of work. Whereas once you become an expert in your field, and that might be it. But in medicine, it's a dynamic system. So things are changing all the time as best practice improves with with time and experience. So forever learning, and they know that. Okay. So scholarship is about continued lifelong learning and trying to keep yourself up to date with the best medical practice that currently exists. Now in Ireland, they use a lot of what we use in the UK in terms of the NICE guidance. So a lot of the guidelines that are used in the UK are also used in Ireland as well. So if you are looking for sources of information to try and get best practice when it comes to management, other than what I tell you, then the NICE guidance will be a key reference guide for you to look at as you're preparing for this exam. Now, obviously, 6 weeks is not a long period of time for those that are sitting in June, but it's still more than enough time to learn about the common chronic illnesses that could be tested, and obviously the acute medical emergencies. But we'll talk about these during the course itself. Professionalism. This goes hand in hand with being a doctor, okay? Being professional, being someone who's sitting in a position of trust. Being a doctor is one of the most trusted professions that one can be a part of. Okay? So professionalism encompasses many different aspects to it. Okay? I'll give you one example. If you're dealing with an angry patient, or you're dealing with a patient who's acutely psychotic, can you maintain your level of integrity and professionalism and not be influenced by the actions, by the words, by the emotions of the patient who is sitting opposite you? There are many scenarios in your exam where you're going to be dealing with a patient who is angry. How do you conduct yourself during this time? That's what they'll be looking at. Okay? Various ethical dilemmas. Are you able to maintain confidentiality? Do you understand when it's important to maintain it and when it's important to break that confidentiality? So ethics and professionalism, there is a big guide to professional conduct and ethics for those that are registered medical practitioners. Again, you don't need to go and read it. It's something that I will cover with you as we look at very specific scenarios that come in your exam. But it's just important to know that this is one of the domains, again, that they'll test you on your level of professionalism, again, in all scenarios. And the final domain is clinical skills. And I will add clinical examinations to this as well. Clinical skills and clinical examinations take up half of your OSCE examination. 50% of your OSCE is based on clinical skills. Now, for the PRES level 3, when I compare it to other international medical licensing examinations, PRES3 is one of those that tests you on clinical skills that are quite varied as compared to the other exams. There are some skills that I have only seen tested in PRES3, and I've not seen them in other exams, for example, PLAB2. Again, there is a list of these clinical skills that you must be familiar with. And as we go through the course, and particularly when I come to Dublin, I will show you every single one of the clinical skills. And by the end of it, you'll be proficient. Once you've had your time to practice, you'll be proficient in performing the clinical skills as the standards that are accepted or required, I should say, in the Republic of Ireland. Okay, and for an OSCE examination as well. So these domains of good medical practice is what you want to base your preparation around. You need to understand that these are the things that you are going to be tested on in some shape or another. Every station won't test all of these things, but certain parts of each station, depending on the actual scenario, will combine some areas of good medical practice. So it's important to know this. Now, the actual exam date and venue. Finally, very recently, the Irish Medical Council, as they always do, they leave things quite late, is release the exam date for the upcoming exam, which is the 26th of June, and it is held in Cork, okay? Cork in Ireland. Now, Cork is becoming, there are four centres in Ireland. You've got Dublin, you've got Galway, you've got Limerick, and you've got Cork. Now, Cork is becoming the centre that I have seen in the last, certainly the last, since COVID, that is the one where most of the exams have been taking place. Yes, Dublin, I believe it's in Trinity College. I believe Dublin in the last couple of years has also been quite a common centre. But Cork is certainly the forefront of the PRES3 examination. And what I can tell you from my experience from conducting this exam for a long time now is that Cork is one of those centres where the exam is a little bit more predictable in terms of what is expected on the actual exam day. And I can say this with confidence because I've been tracking the sort of scenarios over the past few years. It's been 9 years now. And I've clumped them into each of the exam centres, and there's always been a recurring theme with the Cork exam. I don't want to use the term easy. I like to stay away from the word easy for an exam, because when I say to a candidate that an exam is easy, they then become complacent and only focus on those things that have repeated only in Cork. And that is a strategy that I would never recommend. I have done every single medical exam that you could think of. I've done the USMLE, all of them, many years ago. I've done GP exams. I've done MRCP. I've done many exams. So for me, an exam is, I now find exams relatively straightforward, and I enjoy the process of exams actually, because it gives me a chance to showcase what I've learned over the years. But certainly complacency is not something that I take into an exam. I am one who will never leave any stone unturned when it comes to preparing for an exam, because I understand that if I prepare myself to the best of my ability, even if I pass or fail, it won't bother me, because I know that I've given everything that I can to the exam. But if I use the strategy of only preparing the common things that can come up in an exam, and I failed that exam, I'll never be able to forgive myself. So the way obviously, you have a course, and that course gives you all the weaponry that you require to be able to defend yourself on the exam day and bounce off any questions that the examiner may have for you. So you have all the artillery, you have everything necessary to pass the exam. But don't look at this exam, even though it is in Cork, which is a little bit more predictable, a little bit more, shall we say, repetitive compared to the other ones. I want your preparation to be absolutely watertight and solid. From an OSCE perspective, I've lost count of how many people that I have trained for this exam from the OSCEs. I don't remember many, if not any, ever failing the OSCE from the information that I've given them. The data interpretation is a little bit more of a different ball game, and we'll talk about why in a moment when I go into the details of the data interpretation. But the OSCE, because of the repetitive nature of the exam, and particularly with Cork, almost even, and I don't like to use the term weaker candidate. And when I mean weaker, I mean the one who suffers from a language barrier perspective, whose communication skills are not quite there. Even those have managed to succeed in the OSCE part of the exam. Okay, so you can be rest assured that you'll be very, very well prepared. Certainly by this date, 26th of June, you've got 6 weeks. I examine for OSCEs in medical schools for 4th and 5th year medical students. And I've been an examiner for about 4 or 5 years now, and I fully understand the requirements for the OSCE, and I know exactly what an examiner is looking for. So I know that 6 weeks is optimum time to prepare for an OSCE. The longer you take, for example, some people have been preparing for much longer, 6, 7 months, some even longer than that. Some of that information and the ability to communicate dwindles or fades with time. So you need a very focused time frame in which you're only preparing for this, which I understand is difficult for some of you. You've got families, some of you have got work, some of you have got other commitments, some may be getting married, some may be having babies, there may be lots of different, and I have been through every scenario, every single scenario you can imagine, okay, from common to very uncommon with candidates. But the advice I give them every time is, you have to focus on this exam. You have no choice. For me, an exam is a once in a lifetime event. It doesn't happen over and over again. I never look at the second attempt or third attempt or fourth attempt, and I've never needed to, because I know that I will prepare to the best of my ability this time round, so that a second attempt is not going to be an option. Okay. And for those that are a part of the course, the material that you've been going through, and I hope that you have been watching the videos and that you've been going through the material, those materials and those videos are laser focused for the exam, laser focused. Okay, it's very unlikely that anything outside of that will come, but when I do conduct the course, I ensure that I try to cover things that have not just been common scenarios in the past, but that encompass other common OSCE type of stations that could potentially come up as well. So you've got, from now, I would still say that you've got enough time to keep it laser focused up until June the 26th, exam day. I have been hearing that there is another exam in September or the autumn time, which used to be a very common time of the year to sit the PRES level 3, sort of September and October time. And I am almost 99% certain that there will be another exam day, because there's an abundance of candidates this year that have registered for the exam. So for those that are still waiting for eligibility and confirmation from the Irish Medical Council, just hang tight, keep preparing, don't stop preparing, and just keep it going. Okay, there is very likely to be another exam. And for those of you that are privileged enough to sit it in June, then now is the time that everything else in your life goes out of the window and your primary focus is only on this exam, so that you can now start your journey to work as doctors. Because I'm sure some of you, I remember from the last course, I know that there were people from areas that have been riddled with war, and you haven't had the ability to practice what you've spent your life dedicating it on. So this is now your chance to showcase that it's my time to, for all the effort that you've put in through medical school and after medical school as well, is now my time to do again what I love to do and what I need to do as well. So this is the next exam. This is what we're preparing for this time round. And this leads me on to a slide that I didn't really want to put in here, but it's important just from a, just to close all angles of the exam, is that you must have passed PRES level 3 within 2 years from the date of your eligibility. And you have a maximum of 3 attempts. Now, I know from personal experience, and I say personal, I don't mean myself, I'm from personal experience talking to a particular candidate, that they were given a 4th attempt at PRES3. But this is not going to be the case for any one of you, okay? Most of you, if not all of you, should be succeeding the first time round. And the majority of you, I promise you, will be passing the first time round. Okay. the format again. Now, there is a blueprint on the Irish Medical Council's website for everything that could potentially be tested for the PRES3. Similarly, with PLAB2, the General Medical Council has got a blueprint. Now, this blueprint encompasses everything and anything, you know, when it comes to clinical medicine and OSCEs. I would recommend perhaps not going through the blueprint now, particularly for those that are preparing for the June exam. I don't think it's necessary for you to dissect that blueprint. I've already done that for you. That's my role for you. Okay, is to dissect that and give you the information in a way that's compatible enough for you to process, perform, and then hopefully pass the exam. Okay? So the blueprint is there. You can by all means have a look at it if that's something that you want to do. But I would say that you probably don't need to at this stage, particularly if you're coming on the course. I have dissected it for you, and I have given everything within those 7 days for you to succeed in the exam. And the cases used are the ones that represent common medical, surgical, psychiatric, obs and gynae, peds cases that are encountered on a day-to-day, on day-to-day medical practice in Ireland. They are not going to be obscure medical conditions. They're not testing you on that. This is set at the level of a junior doctor, of a senior house officer with only a minimal amount of clinical experience. Okay? So they're not going to come up with weird and wonderful diagnoses, particularly in the OSCE examination. Now, the data is a little bit more of a different ballgame, because I've seen some images in data interpretation that if you didn't spend enough time studying in medical school, you would not have any idea what those things are. Okay? So from a data point of view, you may encounter things that are a little bit more obscure to the more commonly encountered things, but not many of them. Okay? Most of data interpretation is straightforward, common, day-to-day medical things that junior doctors are meant to be able to interpret. ECGs, common ones. Chest x-rays, again, common ones. Not obscure syndromes that people see once in a lifetime. Day-to-day things that you need to actually conduct good clinical work when you're working as a senior house officer. Okay? But as we talk about, as we go through the course, we will go through every single clinical scenario that will come up in your exam. And even those that won't come up in your exam, but that you should be aware of. When I teach for an exam, I don't teach simply to help you pass the exam. I teach in a way in which I don't want to sound overly pompous or arrogant in what I say next, but to become a better doctor, to become a more wholesome, holistic doctor from a clinical skills perspective, from a communication perspective, how to take a better history, and obviously from a management perspective. My role is to make you the best type of doctor that you can, only within a short period of time, within 7 days. And passing the exam should always just be a byproduct of that knowledge that I've given to you. Okay. Now let's get to the nitty-gritty of the actual exam itself. So we've talked about the format. I've told you that there's 2 elements to this exam. You've got your OSCE, your objective structured clinical examination, and you've got your data interpretation. Let me tell you what an OSCE is. Now, OSCEs have been used, they were pioneered actually. They've been used for many, many years, but they've become very popular medical examinations. I'd say since about the 1970s, the mid 1970s, they've been used extensively, particularly in UK medical schools. The term OSCE means objective. Objective means that the examiner is the one who is objectively critiquing you on your performance based on whatever clinical task that you've been asked to perform. And it's objective because you've got multiple different examiners. It's not just a one examiner who's examining you. So you cannot say at the end of the exam that you were unduly discriminated against by an examiner. That's not going to happen in your exam. It will not happen. Even though I have had candidates, of course, there are people that fail. There are people that don't get through. And I've had those people come to me and say, oh, the examiner didn't like me. They looked at me in a strange way. They just had it in for me. That's not going to be the case. I promise you. I assure you of that. Okay. The chances of that happening is almost 0% in your exam. In fact, if anything, the examiner who is objectively marking you on the exam day wants you to pass. They want you to pass. They do not want you to fail. But they have a mark scheme that they must objectively mark you against. You walk into that exam. Let's take candidate number one. Candidate number one walks into that exam day with 0 marks, absolutely 0. The more he or she does, the more he or she says and performs, the more marks they pick up along the way. And there is a set number of marks that you have to pick up along the way to be able to pass the exam, which I'll talk to you about how many marks that you actually need. So just know that the term objective is objective. Don't add your own feeling of subjectivity into it in an exam that has, you have to just eliminate any emotion that the examiner or you think the examiner is showing you. In fact, what I tell people on the course is when you've gone in a station and you've shown them your identity card, and this is candidate number one, and you sit down and you perform your task, your focus should be lasered only on the patient, never on the examiner. Because you've got to think about it in real life. If you're dealing with a sick patient, or if you're taking a history, you're not going to keep looking at your senior every time you do something. You're going to be focusing on the patient in front of you. And that's the same thing that the examiner expects from you, is not to interact with them. They will interact with you if necessary. So just, even if they're sitting in your peripheral vision, just focus on the task, focus on your patient, forget the examiner. When they want to talk to you, they will talk to you. You don't need to turn around and talk to them. You don't even need to look at them. If their eye movements move in a certain direction, or they're huffing and puffing or sighing away, it's not to do with you. Or it may be to do with you if you've done something completely outrageous or dangerous within the station, by which point the examiner will have stopped you by that point, particularly when it comes to clinical skills or clinical examinations. If you're palpating too firmly that you're hurting a patient, then they may stop you and say, they may stop you. Okay? So just forget about the examiner until they interact with you. So that's the first part of the OSCE, is the O, the objectivity of the actual exam. The S means it's structured. Everyone on the exam day is sitting the same exam. Everyone is sitting the same exam. Now, the scenarios may alter from cycle to cycle, from candidate to candidate. I'll give you an example. If you've got a history taking case where you've got diarrhea as your presenting complaint, the patient may give one of you irritable bowel syndrome type of symptoms. They may give another candidate inflammatory bowel disease as a diagnosis. But the overall exam and what's being tested is equal to everyone. And that's where the term structured comes from. Everyone sits the same structure, sits the same type of scenario on any given exam day. Okay? And obviously clinical examination, that doesn't just mean that you're only going to clinically examine a patient. It means that there are 4 domains that you will be tested on in any type of OSCE that you undergo. Number 1, is your ability to take a history. Number two, your ability to effectively communicate in a variety of different scenarios, whether that be challenging communication in terms of breaking bad news, dealing with angry patients, dealing with relatives, dealing with colleagues, or simply communicating about a surgical procedure to a patient, or explaining a medical diagnosis, or explaining an investigation. In the last year's exam, they had a new station that came up about lumbar puncture and how you had to communicate someone who is undergoing a lumbar puncture for, I think it was for meningitis. Okay. How do you effectively communicate that information over to the patient? Now, does that mean that you have to be an expert and performed 100 lumbar punctures? No. Yes, you have to be knowledgeable about the procedure. You may not necessarily have ever performed a lumbar puncture before. You still have to know about it. You have to know about the benefits. You have to know about the risks. You have to know about the alternatives. And you have to communicate that effectively to the patient. So that's the second domain of the clinical examination. The third is your clinical skills, and the fourth is your clinical examination. Clinical examination, I like to divide into two parts. Your first is your chronic stable patient. So, for example, a full cardiovascular examination, a respiratory examination, a gastrointestinal examination. And the second is dealing with an acute medical or surgical emergency. You're acutely unwell patient, you're a deteriorating patient who you have to perform an initial assessment on, your ABCDE approach. So that's the OSCE. Okay? Two parts, practical skills and communication skills. And then you've got your data interpretation, which I'll talk to you about in a moment. From a time perspective, this is very similar to all exams for PRES3, okay? The time frame. So the exam itself lasts approximately, now they use the term approximately 3 hours, 40 minutes, because it could be more, it could be less. Unlikely it will be more, unlikely. It will be less, if anything. And I'll explain myself in a moment why it could be less than this. Okay, and then when you divide the exam time frame into two, the practical and communication skills can be 2 hours and 40 minutes or less, or the interpretation skill, and the interpretation skills is always 60 minutes. Okay, so that doesn't change. That will always be 60 minutes in your exam. And as I've talked about an OSCE, these are the elements that you will be expected to showcase on the exam day in varying quantities. So although you've got 6 stations for practical skills and clinical examinations, the number of practical skills that you have to demonstrate will vary from exam to exam. So it's not just 3 practical skills, 3 clinical examinations, 3 history, and 3 communication. There may be a different number of each of these, but you will have 6 from the first half, which is the practical and clinical examinations, and you will have 6 from history taking and communication. This is not going to change on your exam. Let's focus a little bit more on the practical and communication skills, the OSCE. This is one exam, okay? One circuit that you'll be undergoing. As I've said, it will last roughly 2 hours and 40 minutes, or perhaps a little bit less. And there are a combination of the following: active stations, rest stations, and preparatory stations. There are no pilot stations for your exam. There are some exams where they are testing the suitability of a clinical scenario for future exams. These are called pilot stations. You will not get any pilot stations in your PRES3. The stations that you undertake are called active stations. Those are actively marked stations in your exam, and there are 12 of them, which is actually a lot less than most medical licensing exams. Plab 2, you're doing more than this. whereas PRES3 is only 12. And I believe the reason for limiting the number of active stations is because you've got the data interpretation as well that makes up the second part of the exam. So that's the reason I think that they've reduced the number of OSCE stations, because of the element of data interpretation that they've added to the actual exam. A rest station is self-explanatory. You sit, you rest, you do nothing for that 7-minute period, and then you move on to the next task when your time is up. A preparatory station. Now, this is unusual. Again, not many exams have a preparatory station, but let's take station number 1 and station number 2. And candidate number 1 has lined outside a preparatory station, station 1. The candidate walks inside, no examiner, there's nothing there. There's just a sheet of paper. On that sheet of paper, you have your task, and next to it, you may have some things that might assist you with the next station. For example, an ECG. This is a common preparatory station. So they'll give you a clinical scenario of a patient who comes in with chest pain, and you've got an ECG, you've got some blood tests. You have to interpret those and then perform whatever task you have in the next station. From the previous exam, there were no preparatory stations. This is why I said that 2 hours and 40 minutes could be less, because preparatory stations also make up your 7 minutes. Okay? So they could be less, the timing. But just know that these may be there or they may not be there. It just depends on the exam day. I can't tell you for certain. Okay? What I can tell you for certain is last time there were no preparatory stations. So whatever station that you were stood outside, that was your station that you had to go in, perform within the allotted time frame, and then move on as by station to station as you do in the OSCE. Okay, and each station is 7 minutes in duration. This is a very short period of time. Okay, 7 minutes is not a long time. This is why I say you don't need to go too detailed in terms of preparation, because there's only so much that you can showcase within such a small period of time. There are some stations that you can just not finish in 7 minutes. If you're taking a psychiatric history, how can you do a psych history in 7 minutes? It's not possible, especially for someone who's acutely psychotic. It's not possible. And the examiners know this. So what they'll mark you on is what you've done with the time that has been given to you. And if the examiner, after 2 or 3 minutes, is pleased with what you've performed, then they'll ask you some questions. Okay? They'll ask you some questions. And if you answer those questions appropriately, you will score very heavily. But if you sit in that in the cubicle and you have not got a clue what the task is asking of you, and you go completely blank, then obviously the examiner will try their best to try and help you by asking you questions, but it's very unlikely that you're going to pass. Okay? But by the end, definitely you'll be more than prepared to sit this exam, and those 12 active stations will become very straightforward for you. Now, this period of transfer between one station to another has been a bit varied in the exam in the past, but I have to give you the official, what's officially in the PRES3 handbook. You have 1 minute transfer time. Okay? Now that 1 minute transfer time is literally stand up after station number 1, go to the next cubicle, read the task, and once the 1 minute bell goes off, you have to enter the next cubicle or the next station, if you like. Now, 1 minute doesn't seem like a lot, to be honest with you, on a task that could contain at least a paragraph worth of information. But unfortunately, this is something that I certainly can't change, okay? That's just the way it is. So if you're outside a station and you really feel that because nerves are getting to you And suddenly, even when you're reading, your mind goes blank. When you go into the next station, greet the examiner, show them your identity card, sit down and just tell the examiner, would it be possible if I just spend a moment or two rereading the task? Please make sure you do that. Don't just go ahead and introduce yourself without understanding the full details of the clinical task. Take that 20 seconds initially, read the task again, and then perform it. You're not going to lose marks for rereading the task. You will not lose marks for that. 7 minutes to perform. 1 minute transfer time will be given between each station. You will have instructions when a station ends and when you must move on to the next task. Don't stay in the station. Okay. And when your 1 minute is up, you will have a bell that tells you now you must go inside the next station. And you must go inside straight away. Okay. The practical skills. I've touched upon this already with you, but as I said, it's divided into two parts. You've got clinical examinations and you've got clinical skills. There are a wide number of clinical skills that you must be familiar with for your exam. There are more common scenarios, but there's a long list. And that list is something that you should know all of them, okay? Just because I say that these are more common doesn't mean that the other ones can't come up. Yes, they are unlikely to show up, but you must prepare all of them. Common scenarios that come up in the exam are things like when I talk about clinical skills, IV cannulation, arterial blood gas. In almost all the exams, arterial blood gas, the performance of venipuncture, fundoscopy, which technically is a clinical examination, but it's performed on a mannequin. But there are lots of them, and I will go through every single clinical skill that your exam has ever tested, and that I would expect you to know if you were doing an OSCE. Okay, so those are the clinical skills. The clinical examination, as I said, is divided into two parts. You've got your chronic stable patients, and you've got your emergency scenarios. Emergency scenarios are a guarantee in your exam. Guarantee. Whether that be basic life support and the use of the automated external defibrillator, or the management of airway, whether it may be simple devices to more definitive airways. You have to know all of them. And airway is, again, almost every exam has this scenario where you have to demonstrate your ability to insert airways into an anatomical model, which I will show you when I come to Dublin. And I will show you basic life support as per the Irish medical standards and how to use an automated external defibrillator. When it comes to chronic stable disease, there are a large number of organ systems that you are expected to be able to examine in a systematic, logical approach, whether that's cardiovascular, respiratory, thyroid, rectal, fundoscopy, otoscopy, neurological examinations, breast, bimanual, large number of them. And you have to, unfortunately, know all of them for your exam. Okay. Yes, some are more common than others, but I would recommend and implore you to ensure that you know all of them for your exam day. Communication skills is divided into two parts: history taking and actual communication skills, whether that's breaking bad news, dealing with angry patients, explaining procedures, explaining medical diagnoses, etc. And there is usually, when they test you on communication skills, these are done in isolation, which means that if you're taking a history, you're only taking a history. Because you only have 7 minutes, it's impossible for you to do a history, explain the diagnosis, explain the management plan. It's just not long enough. So you'll be marked on your history taking ability, and then that will be followed by questions from the examiner. Fine, you've taken a history, what would you do next? And you have to explain what your step-by-step approach will be to managing that patient that you've taken a history from. From a communication skills, if you're breaking bad news, you're only marked on breaking bad news. There will be no place in that station for you to take a history. This is why I say when you're doing a station, you're marked on skills in isolation. A history taking is history taking. Communication is communication. Clinical skills is clinical skills. In PLAB2, they often combine the skills into one, where you take a history, you examine, and you manage. Whereas PRES3, it's a little bit more, and this is due to time constraints, they're assessing you on isolated clinical skills in each scenario. But within each scenario, you will certainly have some management that you have to discuss with the examiner. I would say all stations, you will have to interact with the examiner at some point, and that point will come when the examiner wants to interact with you, or if you feel that you've finished a task, you've taken a history, you have no more questions to ask, then you can turn around and thank the patient, and then you can talk to the examiner. Okay, that's communication skills. The individual scenarios, obviously, that's beyond the scope of this webinar today, is to talk to you about individual communication skill scenarios. That's what I'm going to teach you, but it's important to know what comes under this category. This is an example that's taken from the PRES3 handbook about the circuit on the exam day, the actual exam circuit. So if you let's park ourselves outside station number 1. When you receive your examination label during your registration process, it will tell you exactly where you have to station yourself. Okay, for example, either station 1 or station 8, wherever it may be, you must stand outside that station when you're ready to go in, when the exam begins. You see here, station number 1 is a communication station. And then station number 2 is communication. Station number 3, preparation for station 4. And then number 4 is that station that you were preparing for in station number 3. And so on and so forth. So this is how OSCEs are conducted. There is a circuit of stations which contain scenarios that you must perform. And once the circuit is complete, your exam from this half of the exam is over. Last Cork exam, there were no preparatory stations. So you can actually take out 1, 2, 3, 4 stations from there were excluded from there completely. So you've already brought that down now to 16 stations. 4 of them were rest, 12 were active. Now, I'm not sure how many rest stations there were in the exam. There were only a few, and this may vary from exam to exam, but you will definitely get rest stations in every single exam. There will be at least a couple of rest stations, I would say, at minimum. Okay, so this is the circuit that you'll be undergoing on the exam day. So that's the OSCE. Now moving on to the interpretation and the data interpretation skills. This part of the exam has always been, I would say, pre-COVID. Let's talk about 2020, 2021, and prior to this. Data interpretation was a very easy part of the exam, very straightforward. After COVID, they introduced this new computer-based system, which I'll talk to you about. And that computer-based system, I think, increased the level of anxiety of candidates because it was unexpected. The year, I can't remember exactly what year, I think it was 2022 the computer came out. And none of the candidates were informed that their exam was on computer. None of them knew. They actually went to the exam thinking that it was a written exam. They went thinking it was a written exam. And the invigilators or whoever was conducting the exam took them into this computer lab. You know, I'm sure a lot of you have done computer exams before, where you've got a computer station next to each other, and a large number of computers. You log in. Under that 1 hour time limit, you had to then answer 46 clinical questions. And they were really, really thrown back that year. It was unpredictable to me because, it had never happened before and there was no word about it. But at least now we're prepared that either or option can come in the exam. Okay? Either the written based exam or the computer. You have to be ready for both. And when I prepare you for data interpretation, I will prepare you as if it was for both of those. Okay. The last Cork exam was written. It was a written exam where you had a question and an answer sheet where you had to transfer your answers onto. And as I've highlighted on this slide, these are the various skills that are expected. These are the commonly tested data interpretation skills. ECGs are a definite for your exam. Okay? ECGs come in, year out, and they are common ones. If you start looking at rare congenital cardiac syndromes, you're going to, unfortunately, I said to you earlier on, you have to prepare yourself, and you have to prepare yourself very, very well. But you have to also be a little bit focused in what you're looking at and the level in which this exam is tested on as well. It's tested at the level of a junior clinical member of, the clinical staff. So ECGs, common day-to-day ECGs, atrial fibrillation, myocardial infarctions, electrolyte-induced ECG changes, left bundle branch blocks, right bundle branch blocks, heart blocks. So those kind of things are tested in the exam. Atrial flutter, etc. And we'll look at every single one that's going to come up in your exam. And from what I show you, nothing else will show up. Okay? I can say that with quite confidence. Pharmacology and prescribing is, I'm not going to say it's new, but it's certainly not been as heavily tested as it has been recently. Pharmacology and prescribing has become a very important part of data interpretation, one in which most candidates struggle with because they're just not familiar with the format of how Irish prescription charts look, or just prescribing in general because they haven't done it for a long time. And pharmacological drug interactions and common adverse drug reactions, these are really commonly tested themes in your exam. I remember the first time there was a computer exam, I think it was in 2022, there were 8 adverse drug reactions as part of the 46 questions. So they gave you a list of drug interactions. They gave you a list of drug interactions and you had to associate those adverse drug reactions with medication. So for example, they gave you a list of 8 drugs, amlodipine, ramipril, bisoprolol, spironolactone, etc., etc. Then they gave you drug interactions or adverse drug reactions, I should say, side effects, and you had to link the two. And there were approximately 8 of those that came up. And that was very new. That was a new part of the exam. But I will talk to you about this. Okay? Drug calculations. Now, you will not be given a calculator. I've confirmed this many times before. I've asked each time as each exam has passed, have you had a calculator? And the answer's always been no. Certainly in the written paper, there was definitely no calculator present. Okay, so the drug calculation questions is something that, unfortunately, if your maths is not up to par, that you may struggle with, but it will never be a complicated mathematical formula that you have to it will not be that to that degree. Okay? Usually it's to do with drug calculations of commonly prescribed medications. And I'll look at the ones that have come up in previous exams during the actual data course itself. Laboratory blood tests don't come as just a blood test and an interpretation. For example, they're not just going to give you a full blood count and you've got your HB that's low and your MCV that's low and you write microcytic anemia. It won't be like that. It will be in the context of a clinical scenario. So for example, they'll give you a common one is the female with abdominal pain who's got raised inflammatory markers, deranged liver function tests, etc. and you have to come up with a diagnosis and management plan. So the laboratory blood tests and the arterial blood gases are normally as a part of some wider clinical context, and you have to interpret them both together to come up with a sensible either diagnosis or a differential diagnosis, and then the management plan has to be has to be written down or typed up if you're doing the computer exam. Pediatric growth charts, I've not seen it that recently, to be honest with you, but it used to be a very common part of your PRES3 exam, particularly the data part. So I'm going to show you how you plot on the growth charts and how you interpret the growth charts as well. Photographs, dermatological images. I think this part of the data interpretation is what has made a lot of people weary about this half of the exam. Photographs or dermatological images have been very varied in the past. There have been a wide spectrum of different pictures that they have shown in the data. Now, you're not going to get many. So, for example, if you're doing the written exam, one of your 6 questions is almost certainly going to be a photograph. But it won't be one photograph. You'll get 4 or 5 different photographs that you have to simply write the diagnosis next to. Most of those photographs will come from one of 2 sources, I would say. The first one is from the Health Safety Executive, the HSE website, or there is another commonly used dermatology website. It's dermnz.com. That is another place where a lot of the pictures come from. I would say that I have compiled all of the images possible, certainly the ones that have come in the past and the ones that I expect them to test you on. I have compiled them all and put them all into the question bank. There are some others which I will look at with you during the course itself, but you have to be very familiar with spot diagnoses for photographs. And often they won't even give you a clinical scenario that accompanies the photograph. It would just be the picture itself. So you have to be very comfortable with spotting the diagnosis and then writing either on the paper or on the computer itself. X-rays, definitely, chest X-rays, abdominal X-rays. They used to bring in CT scans of the abdomen, CT scans of the brain before. These have not come in recently. I think it's unlikely that CT scans will show up in the exam, but you just never know, okay? And I have put some common ones in the practice questions that you should certainly be familiar with for your exam. Okay? Chest X-rays, abdominal X-rays, definitely you must be familiar with. There is another one that I haven't included here, but that I'll mention to you, is the cardiotocogram, or CTG, or the partogram, that although it didn't show up in the last exam, the first time the computer exam was released, there were 4 questions. There were 4 clinical questions on the interpretation of the cardiotocogram, CTG monitoring. And I will include that within this course this time, and obviously all subsequent courses. I have included that this time around. So when we do the data interpretation, basic CTG interpretation and common pathologies based on abnormal CTGs, I will also discuss with you. I personally don't think that they're going to show up in your exam this time round, but I will just cover them in the unlikely event that they do show up. I'm aware that there are questions in the group. I'm not ignoring you. I will definitely come back to them more towards the end, okay? Now, the computer-based test. 46 questions, some of which had sub-questions that made a part of that 46. So, for example, one question was about an ECG, and you click next, and that will be about the management of that ECG. Okay? So there were not 46 different clinical sets of questions, but they were certainly 46 questions that you have to type your answer in. And you only have 1 hour. I find this a little bit of a disturbing exam, because if they gave you 46 single best answer questions and 1 hour to answer those questions, I would understand. I would understand that, because that gives you, just over a minute a question. But here we have 46 questions that you have to type. You have to physically type the answers in. Or if you're doing the written one, you have to write the answers down. But what I can tell you is that what you write down or what you type doesn't have to be a paragraph of information. It has to be short, sharp, and very concise. When I do the data course, I would tell you what you should write down under each possible clinical scenario. It doesn't have to be a whole monologue, or a whole dialogue, I should say, of everything around that condition or around the management of the condition. Just the basic. If it asks for management, it has to be the basic things that you list in there. So it says type answer under each question and use bullet points rather than full sentences. Okay, and there is no negative marking. Okay, for data interpretation. So if you get a question wrong, you're not going to be negatively marked. You're just not going to get the mark. And how many questions you need to get right, we will discuss with you towards the end when I come on to marking for the exam. Okay, so the computer-based exam, 46 questions. Some of these questions are leading questions. So question number 1 may be about a ECG or a chest X-ray. Question number 2 may relate to the previous ECG. Question number 3 may again relate to the previous ECG. Okay? They're not necessarily 46 different clinical questions. This one is the more likely one for your exam. Okay, you may get the computer one, and actually, they should email you if they haven't already done so, telling you which one that you're going to sit. Because in previous years, they have told candidates whether they're going to sit the written paper or whether they're going to do the computer-based exam. So they will have already told you this, or in the upcoming few days or weeks, they should tell you this information so you're better focused on which type of exam for data interpretation that you're expected to do on the exam day. For the written paper, there are only 6 questions, but each question has a number of sub-questions. Again, let's take dermatological images. Question number 1 focuses on this interpretation skill, and one will have 1A, 1B, 1C, 1D, and maybe 1E as well. 5 different clinical pictures that you have to put up a diagnosis next to. And then next to the on the answer sheet, you will simply put the whatever diagnosis it is, just the diagnosis. Whatever the question asks you, that is what you'll fill on the actual answer sheet. If it's an image, just write the name of the condition. Don't write any more detail than that. Move on to the next one. For example, molluscum contagiosum. If a picture comes of that, write that in. Try and spell it as close to its correct spelling as possible. Again, English is not first language for some of you, so I appreciate that you may not necessarily be comfortable with the spelling of all of these terms. Some may have gone to medical school where they taught medical terms in Latin. Stay away from that, okay? You've got to try and write the terms out in English terms, okay? So yeah, with the spellings, just try and become comfortable with the spellings that are used in Ireland. Again, you have 1 hour. That's understandable. Same for the computer. And each question is marked out of 20. And I'll talk to you about the marking in a little bit more detail as we come to the marking section. But if you see 6 questions, 20 marks per question, the maximum number of marks you can get is 120. Okay? And actually, the same is true for all the exam. The practical skills, the maximum number of marks is 120. The OSCE, the communication and history, 120. And the written data interpretation or the computer is again 120. Exam day, actual exam day. Make sure you go on time. Don't be that candidate that is, catching a flight on the morning or catching a train on the morning. Make sure you're there the day before. Okay. I've spoken to a lot of people about it. It's quite an easy venue to find, the Cork University, the University College of Cork. But make sure that you're staying nearby. Okay. I understand that it can be expensive. I appreciate that. I've been in your position before. I have been someone who's done exams before and have to travel to different parts. I know it's expensive. I appreciate that. But try and stay there the day before. Try not to risk traveling on the morning of the exam. Okay. Be there with ample time and make sure that whatever time is written on your email or your letter, that you are there moments before. You're there with ample time. You'd rather be there early than even a minute late. Then you'll undergo quite a simple registration process. Here, they will give you they'll take your relevant identity document, whether that's your passport or national identity card, driving license, whatever is acceptable, usually a passport. They will then print out an examination label that you'll carry with you throughout the entirety of the actual exam. On the examination label, you have your name, you have your PRES level 3 number, and your medical reference number on it. This is important because as you proceed through each of the scenarios, the examiner will have to obviously ensure that you are the correct candidate sitting that station, and they're marking the correct candidate. Also on the examination label, you will also have your starting place for the OSCE. Okay? In total, the candidates should be expected to be at the venue for about 5.5 hours. Okay. Yes, Paulina, they are the same number. Okay. PRES level 3 number and the IMC reference number are the same number. It will be the same candidate. So you're there for a good chunk of your day. You must be prepared for that. You must be well fed beforehand. When you're preparing for an exam, the day before the exam, understandably, is often the most. It's a very nerve-wracking time, the day before an exam, which is understandable. It's common sense. It would be anxiety-provoking, and I'd be worried for the person that was not a little bit worried. I'd be worried for that person. If you went into the exam as cool as a cucumber or really laid back, I'd be worried for you. I'd be worried because it's likely that the person who's got that little bit of anxiety in them will perform a lot better. But if you go in too laid back to the exam, that may come across to the examiner as arrogance or overconfidence. Now, although they're not going to mark you solely on the way in which you present yourself, remember I told you about professionalism. If you're sitting in a certain way in which you're really laid back and that that nothing phases you, the examiner might look a little bit down on that. So just yes, you have to be calm. You have to be calm, but you have to be collected and very confident as well, but not overconfident. There's a very fine balance between the two. And as you practice, as the more and more you practice, the more knowledge you accumulate, and the more knowledge that sticks inside there, the less likely that anxiety will be a problem on the exam day. I remember one candidate, he sat the exam. He was a neurosurgeon and a neurosurgical registrar, I should say. And he sat the exam. Now, for a neurosurgical reg to sit an exam like PRES3 is understandably a very daunting experience because you've gone from solely concentrating on a very isolated part of the body to needing to understand how to do a bimanual examination or how to collect a cervical screening specimen, I can understand why that would cause a great degree of anxiety for that particular person. And some of you may be in that similar circumstances where where your practice has only been in psychiatry, for example, or in obs and gynae, and now you have to study all the other disciplines that we talked about. So the anxiety will be there. But what he did was, he was from Egypt, and he brought along with him a packet of medication that he thought was a good idea to take on the exam day. And that was propranolol. So he took a beta blocker to be able to wade off the performance anxiety on the exam day. And he fell asleep. He told me the story after. He fell asleep in the rest station. He took, I can't remember how much it was now. I still am in communication with him actually every now and again. He took a more than recommended dose, shall we say, for his anxiety. And because obviously he was in the morning, so in the rest station he fell off to sleep. The invigilator was wondering where this candidate was. They went in and he was snoring away, and obviously the exam unfortunately didn't go very well for him. So anxiety, although it will be there and it should be there, you have to channel how much of that is useful and how much of that is going to be detrimental when you actually, when your time comes to perform on the exam day. Certainly stay away from medications, okay? There has to be something that you do to relax yourself before the exam day. And I never study the day before the exam. Never. I've never picked up a book or read anything. And I'm not talking about medical school. I'm just talking about postgraduate medical exams. I've never picked up a book before the exam day because I understand that if I'm not prepared, if I'm not ready the day before my exam, what on earth am I trying to achieve by cramming in information before the exam day, or even worse, on the morning of the exam? I know many people will do this. I know you will. Yeah? Many people will do this. You'll be on the train, you'll be on the bus, you'll be in a taxi, still holding things, probably listening to me on the videos or reading something. You will definitely, there will be many of you that will do this. But my advice is to get yourself ready to a point where you don't need to do that, where the day before, or at least the second half of the day before, is to zone out and just to focus on relaxing yourself so that when exam day comes, you are totally ready and just ready to sit the exam. That's my advice to you. Everyone's got their own way of sitting exams. This is not the first exam that you're going to sit. This is probably not the last exam for most of you. But find what works for you and stick with it. Forget about what your friend's doing, okay? Because your friend is different to you. Your colleague that you're practicing with is different to you, okay? And also, now is probably a good time because you're at that 6 week mark now that you should be preparing with one another. Don't try and learn this alone. Don't sit in a bedroom with a teddy bear or a mirror trying to do this alone. That is an ineffective way of preparing for an OSCE exam. It's ineffective. What is also ineffective is studying with only one other person. That's ineffective. Because how do you know that that one person, the feedback that they give you, is good enough for the exam day? So it's important, and there's a lot of you sitting on this course, by the way, a lot of you sitting the exam, is to get a wide variety of perspectives on your performance. So for example, how people have done it in the past. Now we live in an era where we don't need to be amongst each other. We can just look at each other through a computer screen. Go on Zoom, go on whatever interface that you have, and interact with one another, prepare with one another, vary the number of people that you practice with. Don't keep it in isolation. Never study alone, okay? Unless it's a theoretical exam, which is different. This is not a theory exam. This is a practical clinical examination that you need people for, okay? That's the beauty of actually having this course, is not so much me. Me, I'm a person who's going to sit here and deliver information from other people. I've never come up with anything novel in medicine. I'm not going to teach you anything that you don't already know. You know everything that I'm going to teach you. I'm just going to teach it to you in a way in which you can use on the exam day. Who is more important than me is the people around you. So utilize those people, um, and utilize a number of you when you practice together. Okay, so that's my little, my take on how you should prepare and who you should prepare with. It should never be alone. It should never just be with one person. Um, and you can also prepare with people who are non-medical as well. You can use your spouse, you can use your sister, your brother, prepare with them as well. They may be able to give you some feedback on your communication skills. So practice, practice, practice is the only way that you're going to clear this exam. And obviously, retaining the information that I give you is going to be important. Me giving you information and you using that information are two very different things. So yes, you have to acquire all the knowledge, then you actually have to use it on the exam day. I can't sit the exam for you, unfortunately, as much as I would love to do that. What to take on the exam day? These are just the basic things that I have compiled from previous students and from the PRES3 handbook. The admission letter that you get, your confirmatory, your confirmation letter needs to be taken with you. Please make sure you take a valid ID. Don't be that person that turns up without an ID, and make sure you've got that ready. Pen and pencils, okay? Pen and pencils, definitely, particularly for the data. If you're writing, you will need this. If you don't take it in, I believe they will give it to you. I don't think they're not going to give you a pen if you don't take one in, but just take it in with you. Okay. A watch, I believe it is only a simple analog watch that you can take in. You cannot take a smart watch in at all to the exam, but a watch is possible that only has a dial on there, and a stethoscope is a must for you to take. Please make sure you take your stethoscopes with you. They're not going to provide them for you. You must take this in. So these are the bare essentials that you must go in with. In terms of what you should wear, this is a difficult one because I would say if I was going to do an exam, I would like to wear scrubs on. I feel comfortable in them. I'm flexible in them. They're not too warm. But I think for the exam day, they will tell you whether you can wear scrubs on or not. But go in smart, okay? Your first impressions they count for a lot, okay? I would go in dressed smartly. That doesn't mean that you need to take your wedding suit out, a tie and a flower sticking out there. You just need to go with a shirt or if whatever females wear, on top to make them smart, and trousers and smart shoes. That will be more than enough. Bare below the elbow, so make sure that any shirt that you wear is below the elbow. Don't go in with a t-shirt on. Don't go in with trainers on or sandals on, even if it's very hot outside, which it may be warm that day. You must go in dressed professionally and smart. A white lab coat, even though I remember I had to wear a white lab coat when I did my USMLE Step 2 CS exam. That was a mandatory requirement for that exam. But certainly for this exam, you will not be wearing a white lab coat on, okay? So don't bring that with you. Dress smartly. Keep your hair nice and clean, tight, put it up. If you've got really long hair, make sure it's tied up. If you wear religious headwear, that's acceptable, okay? Absolutely acceptable. So yeah, just continue with those, but just all electronic devices, etc. Those should not be coming with you. Make sure they're turned off and fully out of sight, okay? As this next slide shows. Mobile phones, notes, textbooks, anything that can help you cheat on the exam, or I know that won't be your what the reason why you'll be taking them in, but anything that could be misconstrued as cheating for the exam day are not prohibited, okay? You have to keep them away, okay? So there is a room in which you can store your valuables. Everyone's got a mobile phone. Everyone's going to take a mobile phone, of course, to the exam, but there'll be a place for you to safely store your belongings make sure that you do not take them into the exam room or center with you at all. But when you do the registration on the exam day, they'll talk you through this in more detail. That will be their role. Okay, the pass mark. How do you pass the exam? This is important to understand how you're going to be marked on the exam day. Let's focus on the OSCE first. The practical skills and the clinical examinations are individually marked out of 120. With each station, the weighting would be a mark out of 20. Okay? So every station that you undertake has a maximum mark of 20 that you can achieve. With a total, if you add all the 6 up, times that by 20, is going to be 120. Same for the practical skills. The data interpretation, whether that's your computer-based or your written exam, will again be marked out of 120. Okay? Now, you must, this is the difficult part of the exam now, and this is one that you want to focus on. You have to pass all aspects of the exam. You can't just pass the OSCE and let's say that you scored 120 out of 120. And for the data interpretation, the pass mark was 60 and you scored 59. You failed. Unfortunately, you have not met the criteria in terms of pass mark. So you have to pass each individual skill that's being tested in the exam. Communication skills, practical skills, and data interpretation. You have to beat the borderline score, the minimally competent score, to be able to get through the exam. This is tough because if you look at the OSCE, it's not marked as 1. It's marked as 2. You would have thought that if you were a poor communicator, but you were excellent in practical skills, that maybe those 6 stations would have given you enough marks to help you get through the OSCE. But no, you have to pass. You have to beat the borderline score in data interpretation. You have to beat the borderline score in communication skills, and you have to beat the borderline score in practical skills. Only then will you succeed in the exam. There is no compensation between interpretation, practical, and communication skills. If you score 100% on one, those marks are not going to be transferred to anywhere else. Generally speaking, for the OSCE, if you are if you performed well, if you've prepared well and you've performed well, it's very unlikely that you're going to fail one of these isolated, for example, you know, the communication skills or practical skills. It's very unlikely that will happen to you. So just remember, there's no compensation, and each one of those individual skills has to be performed and passed. Now, I've been asked for these OSCEs, how is the pass mark set? How do they determine? We need to pass each station in each. No. Well, we'll come on to that. Someone asked, do we need to pass each station in each individual school? No, there is a pass mark. There's a set pass mark, which I'll talk to you about in a moment. I've been asked in the past about this Anjoff borderline regression score and what does it mean? And the answer I've given is it doesn't matter. Okay, it doesn't make any difference to you whatsoever. Now, there's 2 ways in which OSCEs can determine a pass mark. They can either determine it preset, which means that a group of specialists will sit down they'll go through each clinical scenario and they will say, what would the minimally competent but safe doctor perform at that level for this station? And if that is 12 out of 20, then the pass mark for that station is 12 out of 20. Okay. So the number may either be preset. It may be preset. So for example, practical skills. Out of 120, you need 80 to pass. That number may be preset by these specialists because they've added the minimum score that a doctor is expected to get for the station, add those minimum scores up and come up with a borderline score in which the candidate must either they must either equal or surpass that number. Or they may determine the score based on candidate performance on the actual exam day itself. Yeah, the actual exam itself, which means that based on the 40 or 50 people that sit the exam, they take a total of those marks and they have a sort of borderline average score. And those that have surpassed that score have passed. Those that didn't quite get that score have failed. So they can either preset the number. So data interpretation, you have to pass 60 or more to pass this. That's a preset number. Or they may determine it on the exam depending upon how the candidates actually did on the exam day. Whichever one it is, it makes no difference to you at all. It doesn't make a difference because you have to do the best that you can do. If your aim is a borderline score, then don't sit the exam. There's no point. You might as well withdraw your eligibility now, save the money, and go and do something else. Because for you to aim for a borderline score, even if you've been out of medicine for a long time, your aim should not be a borderline score because you're not going to do well. I have spoken to these people. I have sat with these. I know the mentality and I understand. I've been a student before. I've been a junior doctor before. I understand that I just want to get through the exam. That mentality is going to work against you. Okay. You have to go in with the mentality. You have to go in with the mentality that I'm going to pass everything. Everything. I'm getting 120 in every domain, not 65 or 70, and I'm going to get through. 120. If it happens, it happens. If it doesn't happen, with that mentality, you're more likely to pass than not. But if you go in with a borderline regression mentality where I need to work backwards and I need to just get 65, and I know from my experience, or Dr. Karam is telling me that I only need 65 to pass, that I'm just going to go with that. That's nonsense. It's the complete wrong way to prepare yourself. My 7-day course is not to prepare you to be an average, mediocre candidate on the day. My role is to instill confidence, knowledge, experience in you so that when you go to the exam, I am prepared no matter what. Okay, I don't give a damn what the score is. I don't care what the borderline score is. I'm going there to pass 100%. Okay, so let's have a look at the next slide, and this will put the numbers into a little bit of perspective now for you. This is just an example. Okay, this is a real life example, but just an example. Following standard setting, the pass marks for the 3 components were as follows. You can see on the left column, you have communication skills, you have practical skills, and you have interpretation skills with a maximum of in each of 120. Okay. These were the scores in which you had to equal or surpass to be able to pass the exam. So for example, for communication skills, it was 63.5. For the practical skills, it was 74. And for the interpretation skills, it was 63. Again, this tells me this information tells me a few things. Number one, the pass mark itself is not equal for the three. And it will never be equal in even your exam. It's not going to be 60, 60, 60. There's going to be a difference in the number. Okay. So you can't aim for a certain borderline score because you don't know what that score is going to be. That's the first thing. Okay. That's the first thing to look at, is that the borderline number is not going to be the same. The second thing is that the communication, so that's the first thing, that all the numbers are the same. Yeah. We've already mentioned that you have to beat the borderline score in each of the domains to actual pass the exam. You don't, this was to answer the gentleman's question in the group, or the lady's question in the group. You don't have to pass every station. And there are not a set number of stations that you need to pass. You know, like Plab2, you have, for example, you need to pass 12 or 14 stations, and you need to beat a borderline score as well. That's not the case here. It's not the number of stations that you have to pass. So you can fail a station, you can fail 2 stations, but you have to make sure that you beat the borderline score. Obviously, if you start to fail stations, the number of marks that you're going to get is going to come down considerably. Okay, that's why I said your aim should be to pass everything. So for this candidate, a failure to meet the required standard in the practical skills means overall fail. So if for example, this person had failed 1 practical skills, but passed the communication and passed the interpretation skills, but still unfortunately did not get through. So that's the way the exam is marked. Those are the way the marks are distributed. And these are the borderline scores that you need to get. These are not the numbers for your exam. The numbers may vary. They may be more, they may be less. They may be more, they may be less. But they're going to be roughly around, I would say, between 60 and 75. I have seen it higher before. I have seen it as low as 58 before. Okay, so they may vary from exam to exam, but your aim is always 100%, which is realistic. For the OSCE, it's very realistic. You're going to be given all the answers. All you got to do is utilize them. Okay, so it's very realistic to get maximum marks. And I have seen people perform outstandingly in all 3 domains before. I've seen many candidate feedbacks with absolutely outstanding performances. Okay. And the final thing to mention about this is 63.5 divided by 120 is a little bit more than 15%. Little bit more than 15%. 50%, I beg your pardon. 50% is a really, really low percentage for an OSCE. Really low. And it is around this, your pass mark, by the way, for most exams that I've seen, around 63 to 65. That's a very low percentage. Okay. So at least for those people that don't take on board what I'm trying to instill from a confidence point of view, at least you know that you don't need to be 100% on the exam day. Okay, you don't need to be. I want you to be, but you don't need to be. And that's important because the examiner is not going to expect, particularly for the OSCE, they're not going to expect perfection from you. It's not possible. Even if I was to go and sit the PRES3 on 26th of June, I'm sure that I'd pass the exam, but I'm sure that I wouldn't get 100%. I'm sure of it because you've got a lot of factors. There's a lot of human factors that have to be taken into consideration on that exam day. And these human factors are what the pass mark encompasses. So that 63.5 is showing what the safest, minimum safest level of doctor should be able to perform, to be able to say, yes, I'm happy now that this doctor has the communication skills to be able to work within our healthcare setting, or this doctor has the practical skills or the interpretation ability to be able to work safely amongst Irish healthcare workers. Okay, so it's not 100%, although your aim is going to be that. This I've taken from the PRES3 handbook. If a candidate has deemed to have made a clinical error that compromises patient safety, e.g. not properly clearing the airway at the start of a resuscitation procedure, or endangers themselves, their patient, or their surroundings, e.g. not disposing of hazardous material, e.g. sharps in the correct manner, it will result in the candidate failing that station. This is not an exaggeration. Okay, this is word by word taken from the PRES3 handbook, and I know from experience that this has happened. Okay, patient safety is at the forefront of this exam. 7 minutes is not enough time for the examiner to say, this is a good doctor, this is a bad doctor. It's not possible. But 7 minutes is more than enough for an examiner to say, this is a safe doctor, this is a very unsafe clinician. And that's what they're looking at, okay? Are you safe? If you take a venipuncture station, arterial blood gas, cannulation, intramuscular injection, suturing, subcutaneous injection, and you fail to dispose the sharps into the sharps bin, you have failed that station. Even though you may have performed the rest of the exam, or the rest of the station wonderfully well, but just that one slip of the mind and you didn't put it in the sharps bin, you have failed that station. And what a tragic way to score 0 on, just by not putting something in the sharps bin. And when you've got a mannequin, for example, a lot of these practical skills are performed on mannequins. You have the equipment sort of nearby. You have a sharps box for the sharp stations right in front of you in either yellow or orange, bright fluorescent color in front of you. Make sure you use it at the appropriate time. Okay. And the only reason why I've put this slide in is to show you that this exam, because of the time constraints, cannot afford to allow any patient safety to be compromised at any point in the exam. If you palpate too hard on a clinical examination, you're going to fail. If you don't dispose of sharps correctly, you will fail. Okay? But if you don't perform a clinical examination from A to Z in the correct order, that doesn't mean you're going to fail, but that will obviously alter the number of marks that you get. So patient safety compromise will result in the failure of a station. It's unlikely to happen to any of you, but don't fail for a patient safety reason. And finally, before I open the floor to any questions, is what are the common mistakes to avoid in the exam? This is important, okay, because if you can avoid making these mistakes, you increase, and then if you add on medical knowledge to it and rigorous clinical practice, keep practicing, you're not going to fail the exam. It's very unlikely that it's going to happen. Okay. So these common mistakes are for all of you to avoid as far as you can for the exam. Rote behavior. I know, I've been teaching a long time, okay? I know rote behavior. Inside, I could tell from someone who has read from a script and someone who has not read from a script. It's obvious. You may not think it, it's obvious. And an examiner 100% will know. Reading from a script doesn't mean that you're going to fail. Of course it won't. Okay? That script may have a lot of information on there to pass past this, the scenario or station. But rote behavior is that you've learned a script, and if someone throws you off one way or another, you're finished. You're gone. If they say one question that is not in your script, and you don't know the answer to it, and the script didn't tell you how to respond to that question, and you get flustered and you start to panic, the examiner is going to know that this candidate has literally memorized a script. I know everyone does it for Plab 2. I know. I have been teaching this a long time. For PRES3. PRES3 less so, because I try not to teach you from a script. I try and teach you how to perform a skill, how to take a history, how to communicate effectively. It's not scripted. You're not going to pass if you go in a scripted format. It's got to be natural. It's got to be conversational. It's got to be reactive. You've got to react to the situation. For example, if the history taking scenario comes in for diarrhea, and Dr. Karam Singh told me that it has to be inflammatory bowel disease, it has to be, or colorectal cancer. But the diagnosis in the exam was something completely different. But everything was stuck on IBD. You're going to fail. How are you expected to pass? So you've got to be flexible. You've got to be dynamic. The overall approach will be the same, but you've got to be a little bit flexible in terms of understanding that things may change. It's an exam. I don't set this exam. I don't write this exam. Okay. You have to be flexible in your approach and not just study off a script to learn it word by word. That's going to work to your detriment. That's why I've put it under a common mistake. Okay. Learn, practice. And then the more you learn and the more you practice, the better you become. You start to weed away all this scripted bit. You won't need a script then. Okay? So rote behavior. Some of these points may seem very small to you, and it doesn't matter. Can small points can often make the greatest of differences. I have seen people, I assure you, I have seen feedbacks of people failing by 0.5 marks in the OSCE. I've seen it with my own eyes. Don't be that person, okay? Do not be that person. So don't be the person who overlooks little things. This next one, everything you tell me will be kept confidential. This is more for history taking. When you're doing a history taking, there's a way in which you introduce and you move into the history. When I do the course with you on the 24th and 25th of May, I believe is, I will tell you how you introduce yourself in a history taking, where you eliminate the use of these questions or these statements. Everything will be kept confidential. When you work as a healthcare professional, everything should be kept confidential anyway. That is one of the it's one of the ethical principles of good medical practice, that everything is kept confidential until special circumstances advise for the exposure of whatever it is that you're trying to keep confidential. So patients understand that. There may be certain clinical scenarios where patients may not feel comfortable in opening up about things that are very confidential to them. For example, psychiatry, mental health patients, or gynecological cases where you're dealing with sexual health. If a patient is not forthcoming with information to you and you feel that, okay, is it because they feel that I may go and tell somebody else? Then you can remind them about the principle of confidentiality, that everything that is discussed here today between myself and you will be kept confidential between us and anyone else involved in your clinical care. But this is not a phrase that you need to go in and use in every scenario, because confidentiality is assumed in every clinical scenario. May I ask you a personal question? This is coming on, again, more relating to history, and people often throw this question in when they talk about smoking, alcohol, drugs. I've been to Dublin many times in enough to know the the endemic problem of drugs, of alcohol in particular, of cigarette smoking. I know it is inherent in that society for people to do these things. Okay, similarly in the UK. But these are not personal questions. It's not personal to smoke. It's not personal to take drugs. So you just ask the questions. Again, when I talk to you about history taking, I will go through all this in more detail with you. But if you're going to ask a question where you feel it is about lifestyle, poor lifestyle choices, you don't need to worry about putting statements like, may I ask you a personal question? Just ask the question. You're there for that reason. And this one, may I ask you some questions? Even recreational drugs is not personal. Okay. Yes, they may do it for themselves. It's not a personal thing. Okay. Society and they, it's their choice. Okay. But you don't need to. You just ask the question. May I ask you some questions? Is that okay? This is a common mistake that I see in history taking. Hello, my name is Karam Singh. I'm one of the junior doctors working in A&E. Can I start off by confirming your name and your date of birth, please? And they'll give you the name and the date of birth. Okay. I understand, Mrs. Jones, that you've come in today with complaining of bleeding from your front passage. May I ask you some questions? Would that be okay? No, that's not the way you introduce it. You don't need to do that. Okay. May I ask you some questions? You're there for that very reason, to ask them questions. Okay. So it would be, hello, my name's Karam. I'm one of the junior doctors working in the emergency department. Can I start off by taking your name and your date of birth, please? Nice to meet you. What would you like me to call you? Mrs. Jones. Mrs. Jones, how can I help you? What brings you in today? And they'll give you the presenting complaint. Rather than saying then, can I ask you some more questions to try and figure out what the cause of these symptoms may be? You then go into it by saying, now tell me more about that then. So keep it open-ended and you tell me more about that. How do we signpost for social history? We will talk about this during history taking, but signposting is an important part of history taking when you're moving from one part of the history to the next. Okay. For example, if you're moving from your differential diagnosis or your red flags to social history, you then tell the patient, I now need to ask you a few questions about your health, your general health, and your lifestyle. Will that be okay? So yes, signposting is important, but this may I ask you some questions at the initial part of this station should not be there. It should be an open-ended statement. Tell me more about your symptoms, and then you move into the rest of your history. But we'll talk about that. Okay. Refer the patient to the internet. Never do this. Okay. At the end of a station, it becomes, even though, by the way, in my clinical practice, I, as a GP, use the HSE website, even though it's for Ireland. I use the HSE website all the time. It is one of the best patient-directed, like our equivalent is the NHS. The HSE is adapted from the NHS, but far more detailed than the NHS website. It is an amazing place to gather information from for your exam. That's why I said to you, for those that are part of our group, use the HSE website when you're studying certain common conditions that are going to come up in the exam. It will give you a wealth of up-to-date information and also words that are used directly at patients. So in patient-directed language that you can try and incorporate into your OSCE. So the HSE website is a very great source of information. I use it all the time. But referring patient to the internet, although yes, we do it in real life, I would say from an exam perspective, try and stay away from. You can offer them patient leaflets that have been generated by your particular hospital. That is acceptable to use. But I think referring to the internet is something that we should try and avoid. Okay. Not reading the station's instructions carefully is, well, let's say you've done the course and you know every scenario that's going to come up in your exam. But you assume that when you look at the task from the first sentence or so, rectal examination. Okay, I'm not going to read any more now, and I'm just going to go in and perform a rectal exam. You're going to perform poorly because there is information in that task that you will need to use when you discuss management, etc. Or they may be asking you to do something else. Okay, so always read the station instructions very carefully. There may be hand gel that is outside the cubicle. Make sure that you use the hand gel to decontaminate your hands very carefully. Okay, there will be invigilators looking around, making sure that you do this. Or if there's not hand gel outside, then there certainly will be inside that you must use, particularly if you're doing a clinical procedure or a clinical examination. Make sure that hand decontamination is a big part of your exam. Just get into the habit of using hand decontamination when you're doing this exam, when you're preparing. If you haven't read the instructions carefully enough because time has elapsed, then you go inside, tell the examiner, I'm really sorry, would it be okay if I have a look at the clinical notes again, please? And they'll never say no to you. But if you have to keep reading it too frequently, that will bring your marks down. Okay? And if the notes are next to you, don't keep looking down at them. Maintain eye contact with the patient. Maintain eye contact that is, not overpowering. You can't just keep staring at someone for 7 minutes. You have to try and look away. But when you look away, make sure it's not looking up to the sky for, divine intervention. It's got to be very natural where your eyes wander in the station. Don't let them wander on the task too much, because the examiner may feel that you're not confident in this particular clinical scenario. Okay? Read them carefully. If you haven't got time, read them again. Other mistakes. Yes. The first one is don't bullshit. What that means is if you don't know something, you don't know it. You're better off not to make things up. An important part of OSCEs is that patients know that you are at a certain level within your medical career. They know that. They know you're there to learn. They know you have seniors. They know you have colleagues that you can ask information from. They know you know where to find that information from. So it's more than acceptable to turn around and say to them, unfortunately, if they've asked you a question, I don't have the answer to this question right now, but I can do one of two things. Either I can get the information for you, or I can ask one of my senior colleagues to give me this information, or I can ask them to come and speak to you directly. But don't make it up, because you're going to get caught, particularly when talking to the patient. When you're talking to the examiner, it's okay to give them your investigations and your management, which may not be perfect. So you're not making up things. You're trying to talk through what your management strategy will be for the patient. This don't bullshit is more for the patient. Don't make up things if you don't know the answer. They appreciate you're there to learn. That's what that scholarship domain was all about. It's a lifelong learning process. But the less knowledge you have, the less information you give to the patient, the less marks you're going to accumulate in any given scenario. Offering analgesia is something that candidates, unfortunately, when it comes to history taking, don't do correctly. You're going to get headache stations, abdominal pain stations, chest pain stations, joint pain, back pain. These are very common in PRES3. Someone comes in with pain. Although it's important to acknowledge that they have pain, I'm sorry that you're in pain, and I can see that you're in pain. Would it be okay if I perform an assessment, ask you some questions and perform an assessment to try and get you the right type of pain relief? In that circumstance, it's important to tell the patient in a nice way that I acknowledge you're in pain, but for me to give you the right pain relief, I need to assess you first, but you'll try and be as quick and as thorough as possible. Don't give someone pain relief without assessing them first. If someone comes in with a headache and you're dealing with meningitis or subarachnoid hemorrhage or trauma to the head, do you think simply paracetamol will be enough? It may be enough, but we don't know until we fully assess them. They may be allergic to medications. They may have a contraindication in their past medical history to medications. So I can't just prescribe medications until I know that it's safe to do so and that I'm confident I have a diagnosis in mind that I can treat, that I can offer analgesia to. So don't offer analgesia, but always acknowledge emotion. I'm sorry that you're in pain. I'm going to perform an assessment now to try and figure out what might be causing your pain, and then that will allow me to offer you the right type of pain relief medication. Okay? Getting the name of the patient wrong is a difficult one when you're dealing with 12 different patients who may all have different names. They may have Irish names that you're not familiar with. You know, one maybe Mrs. Brown, Mrs. Smith, Patrick. There may be lots of different names that you may encounter in the exam. It's important not to get the name wrong and not to call Mrs. Brown, Mrs. Black, etc. You've got to try and remember the patient name. Don't ask the patient halfway through, what's your name? Again, it might be on the task. Or if you don't know what the patient's name is because you've completely forgotten, then you need to try and tactfully, communicate in a way in which you don't need to mention their name again. Okay? So try and remember the name if you can. It's important, certainly not to get the name wrong. Although I appreciate that this is not easy in an exam setting. Not knowing how to use a particular mannequin for clinical skills and clinical examinations is not a mistake. It may be an error in lack of preparation. So you have to be familiar with the different types of mannequins that come up in the exam, and there are an abundance of those that need to be touched, practiced on, which I'll bring to Dublin when I come. I appreciate there's a lot of you this time, but I will, we'll do our best. But I'll certainly, the mannequins that I use for the course are the same mannequins that you'll get in the exam. So that's something that I can assure you about. Okay? So practice those. And there are websites that you can use to look at clinical skills as well. There's no harm in doing that. But I think with those, what you have to take into consideration is that those websites are not preparing you for PRES3. They may be preparing you for PLAB2. They may be preparing for general OSCEs, fifth year medical student exams, etc., etc. Whereas PRES3 is a little bit different in terms of time constraint and how much you can perform within that time that's given to you. But I will go through everything with you. Problems with psychiatric stations. So psychiatry is something that comes up almost every single year, every single exam for PRES3. So psychiatry is definite something that you have to be familiar with for your exam, okay? And I will talk to you about psychiatry, how to take a psychiatric history, and how to manage common psychiatric stations in your exam. Lack of basic knowledge, well, hopefully by the end of the course, that won't be the case for any of you, okay? Lacking basic knowledge. And I believe this is the final one. Not behaving as you would in real life. That takes me back to the first rote behavior, scripted type of way of presenting yourself when you're doing an OSCE. You have to be very natural. You're all doctors, okay? All of you are. So, however, yes, there may be aspects of your clinical practice that you may have to adapt for this exam because it may be different in different countries how you come across as a doctor. I know that certain countries have got a very different communication approach. You know, they've got a very, we use the term paternalistic approach, which is I tell you this is what you have. I tell you this is what I'm going to prescribe. This is what you should take, and that's it. And the patient, through whether it may be lack of education, lack of knowledge, whatever the reason may be, just blindly has that faith that they trust the doctor to do the right thing on their behalf. UK, Ireland, America, these nowadays people are a lot more well informed, particularly with the internet involved, the evolution of the internet. People are a lot more informed now. Okay, so you have to take a more patient-centered approach, and your exam will be expecting that from you, that you involve the patient in your care as much as possible. Okay? From a history point of view, communication, involve them in their care, give them the options. So that's what not behaving as you would in real life means. Offering chaperones when not necessary. The guidance is quite clear on the offering of chaperones. These are for intimate examinations only. They do not need to be used for examination of non-intimate parts of the body. Okay? Some candidates will prefer to offer a chaperone in every station. It's not necessary. Okay? If you're examining a rectum, a breast, a testicle, a catheter, gynecological examination, bimanual, cervical screening, then a chaperone is mandatory in those cases. Okay, so it's not just the offering, but explaining that a member of the clinical staff will be present, usually your examiner, for the entirety of the examination. So don't offer chaperones when not necessary. When I do the clinical examinations, I will tell you as we go through each clinical scenario whether a chaperone is not necessary or is necessary. So, for example, if you're a man doing a cardiovascular examination to a female, then chaperones are necessary. Okay? Because a chest is intimate to a female. Or even sometimes when a man examines the abdomen of a female, often a chaperone is necessary. So when the necessity is there, I will inform you, okay? But don't offer them in every case. A knee is not intimate. It never will be intimate, okay? So a knee is not necessary. An elbow is not intimate. A shoulder isn't intimate. But we'll talk about that. Lack of empathy is a big one. If you lack empathy, this takes me back to the offering analgesia case. When a patient comes in with a symptom of pain, whether that be chest, head, back, knee, anywhere, and you don't acknowledge that pain and say, I'm sorry that you're in pain. I can see that you're suffering. We're going to try and get you the right help. And then you move on. That's showing that you've acknowledged what they're undergoing and you've shown empathy through your words. That you understand that if you had a migraine, you'd want the same level of understanding from your doctor. So you have to show that in the exam. When it's breaking bad news, when dealing with angry patients who there's been some medical error, you have to show empathy. Okay, and we'll talk about this, quite again in a lot of detail. Poor behavior. I'm not going to go into too much about poor behavior. There have been instances where you, under exam stress, will maybe say things untoward or out of turn or out of character for yourself, but you have to make sure that your behavior is professional from start to the end. For those 6 hours, you have to make sure that you maintain the highest degree of professionalism. Okay? Ensure that. I remember, you can read it actually. There was a it was a Plab2 exam. I think it was pre-COVID, and there was an there was an argument that broke out between the candidate and the examiner. The examiner was pushing the candidate so much, and I think it was in basic life support, I believe, that the candidate got so irritated, they started to attack the examiner, and the police were called that day. It was in the Manchester Centre for Plab2, and the police were called out that day. It's on the internet. You can read it actually as well. So that's poor behavior is not that extreme, but I'm just saying that you have to ensure that no matter what happens around you, that you just maintain calmness and professionalism throughout the exam. Okay, no matter how irritated, even in an angry patient station, you get, don't start, Don't start giving it back to them. Poor examination technique is similar to not knowing how to use a particular mannequin. You need to be able to examine someone in a systematic, in a very systematic format, which I will show you. Oversimplifying names of the body parts is, again, a lot of people nowadays are well informed and they understand what, basic medical terms. Obviously, you can't use too much medical jargon in the exam. You have to try and keep it in very simple layman's terms, but don't oversimplify things in the exam, and don't patronize people assuming that they won't understand anything that you're saying. So layman's terms are important. This is where the HSE website is a great source of learning those layman's terms. So certainly at some point, have a read through the HSE website of the common conditions, so you get into the habit of using those appropriate words and phrases. Scattergun is a very illogical, haphazard scattergun approach to the station. So, for example, when you're taking a history, there is no congruence to your history. It is all over the place. You've gone from history of presenting complaint to past medical history, and then you go back and forth, and there's just no link from one part of the history to the other that shows the examiner that you are following a logical sequence of events. Or when you're doing a clinical examination, there's just no logical sequence. Examiners who do OSCEs know the logical sequence of events. They know it. Okay? So when you follow a video online, most of those videos try and teach you in a way in which the examiner expects it to be performed. Okay? And obviously when I show you, that will be the way in which you should ideally be focusing on when you perform it on the exam day. And the final two, the penultimate one, is not finishing the station. I don't think this is too relevant for your exam, because from my feedback that I have got from previous candidates is that the examiner will stop you at certain moments and start asking you questions. Okay, so there's no actual end to the station. The end will come when the examiner is satisfied with what they've heard, and then they'll move on to their questions. Some stations don't have a finish. If you're doing breaking bad news, you're not expected to break bad news about bowel cancer in 6 or 7 minutes. It's not possible. Someone who, if you're following the steps of breaking bad news and you're in that true situation, it takes a lot longer. And they know that. That's why I say they only mark you on the things that you have done in your task. So not finishing the station is not too relevant in your exam. But staying in the station after the time is up is a problem. Okay, if you feel that you have not performed something well, and you feel that I need to show someone something, I need to show this examiner that I know the information, I know, just stand up and leave, because all you're going to do is you're going to remove time from that 1 minute, and you're going to perform poorly on the next task. Okay, and when one task is up, when station number 1 is up, you have to forget about it. If you carry station 1 through the exam and you did very poorly in station 1, you're not going to pass. Those are the candidates that don't pass the exam, when they hold on to poor performances in one station and they carry that through. You don't have the luxury to do that. You only have 12 stations to perform the best that you can. If you perform poorly in one, get over it, move on to the next task. Okay? And that's it. That is everything about the PRES exam, other than the medical knowledge, which is to follow. Now I will open up the floors for any questions. I am mindful that I've gone half an hour over. Unfortunately, this is what I'm like. But I will open the floor for any questions that you guys have for me. Let me allow you to unmute yourselves first. Okay, so any questions from anyone. Let me go through the chat as well. I'll have a look here. Let me go back to the top. All right, let's have a look. So let's go from the top. Someone said, why is the course in Dublin and the exam is in Cork? I can't answer that. Unfortunately, I can't answer that question. It's always been in Dublin. I've never done it anywhere else. And they are 3 days in a row. It's from the 14th to the 16th. What were the stations in the previous exam? Can you share that if possible? I have shared it into the group. All the stations actually from the past 4 years have been shared into the group, so you can have a look at those. Okay. Does it mean that about 20 to 40 students will be tested at a centre in the 7 hours? Yes. So I believe the number of candidates is around 48 candidates on any given exam day is the number that they can test. I believe it's 48. Is it comparable to PLAB2 in a way, asking about the OSCE part, practical part, communication part? It differs from, yeah, that's a good question. So PLAB2 and PRES3 are similar in terms of they are an OSCE, but the manner in which the OSCE is presented to you on the exam day is very different between the two. So I would say that the focus of this should be heavily PRES3 focused and not using PLAB2 material. Otherwise, you're going to come unstuck on the exam day. Yes, PLAB2 knowledge will help you in PRES3 and vice versa, but it's too unique and specific an exam for you to use PLAB2 material for, I would say. And I've always given the same answer. Right, okay, so in PRES3, do we have combined, or do we have SimMans? So the SimMan stations are not SimMans as such as they have in PLAB2. The emergency scenarios, the acute medical and surgical emergency scenarios are not simulated mannequins. They are mannequins, but they're not the SimMan that you expect in PLAB2. They're a mannequin that simply lies there. There's a monitor attached to the mannequin with obviously the patient's vital signs. And you have to perform an A to E assessment, but all the information that you need during that assessment is given to you by the examiner. Okay? Everything's given to you by the examiner. So if you ask for a rash, the examiner will tell you if there's a rash present or not. If there's bleeding, the examiner will tell you. So although it's not a real patient you're doing an A to E on, it's not one of those simulated mannequins that the PLAB2 have. Someone said, when are we getting our eligibility email from IMC? You should have started receiving the eligibility by now. The confirmations should slowly start to trickle through. I think a lot of you have emailed me already that you've got confirmation for the course, for the exam itself. But certainly over the next week or two, you should start to get confirmation if you are sitting this exam or not. It's over one day. There's not that many seats for one exam. I think the maximum is 48. So once it gets to that, they're not going to let anyone else on. Could you make an online complete OSCE course for those who can't? Could you make an online complete OSCE course for those who cannot attend it in person? That's exactly what's going to happen. So it's 2 days data interpretation, 2 days history and counseling, 3 days of practical skills. The 3 days of practical skills are live and also online. So those who can't travel will also have a chance to be a part of it. What should we use to prepare for the examinations part of the exam ahead of the Dublin course? So if you look at the notes, everything is there from an examination perspective. Clinical exams, emergency scenarios, practical skills. Nothing out of those will come in your exam. If you want to use videos, etc. for it, then I would say Geeky Medics is probably the only reliable source that I would use for your exam. And there is another one called Oxford Medical Education. They don't have many videos on there, but they have certain videos on there for example, inhaler, nebulizer, oxygen delivery devices that you could also use. But yeah, use the study material for the examination part and really get those steps in mind. And then obviously when the course comes around, we'll go through everything. If we didn't get a seat in June, can we attend the online lecture and the practical course near the exam? Yes. I'm my course has never changed. I've only ever been in Dublin for 3 days. I've only because I don't live there, so I have to travel with all my equipment. So I'll be there on the Friday the 13th, and how I do it is the 14th will be clinical examinations or practical skills, one or the other. The Saturday will be or the Sunday will be the other topic, so either clinical examinations or practical skills, and then the final day is a practice day where you can just practice on the mannequins. I'm around supervising, ensuring that you're doing it properly. I can't come for any longer. I've never come for any longer. Actually, it's always been the same length of time because I don't live there. uh, is there a chance we will have to wait for a queue to start OSCE station? All the 48 candidates cannot go through 12 stations. Yeah, good question, Paulina. So the OSCE, not everyone's doing the OSCE at the same time. Okay, half of the people are doing the data interpretation, the other half are doing the OSCE, and then they'll cross over. Okay, and obviously you don't have one sitting; you'll have 2 cycles on the day as well. So not all 48 candidates are going to be sitting on the same time. Do we have to do a systematic review in every case? I don't know what that means. You're welcome to speak. Is anyone able to unmute their mics? Or no? Roman, let me ask him what that question means. Like doing a review of every system. No, I'm not going to answer that question at the moment because you're focusing more on history taking. So we'll talk about that when we do history taking specifically, okay? But no, you don't have to do a general systems review. What's important in the 7 minutes when you're taking a history is that you do your presenting complaint, history of presenting complaint, you do your differential diagnosis or red flags, then you do your past medical history, etc., and then you move on to the ICE, ideas, concerns, and expectations, then the diagnosis, investigations, and management. Okay, I have. You can ask me questions if you want. Do we discuss management with the examiner? Yes. Most cases, if not all of them in your exam, is not going to be management and diagnosis with the patient, but will be with the examiner. Okay. The previous year's cases are available in which group? If you're not in the course group itself, there is another group, and I will put all the previous examples into that group as well. Okay. For the previous 4 years. Right. For now, I will send the recording into. I think it's going to go on YouTube. The recording is, and I'll put it into the groups. Watch it back, go over it again. It's quite similar to what we did last year, but obviously just updated with the dates and a few other extra things. So have a look through this, and then obviously for those that are sitting in June, begin your preparation if you haven't already done so. I've seen in the group that people are being very active now, which is good. Practice amongst yourselves. It's important to do that now up until your exam. Okay. Is it possible to attend your OSCE? Yes, it is. The OSCE is on the 14th to 16th. The dates have all been put into the groups. Data interpretation is going to be the first, which is 17th and 18th of May. Then I'm going to do the history and communication skills on the 24th and 25th of May. Then I have a very busy 2 weeks because my wife, who is in this group at the moment, is giving birth on the first week of June. So I will be busy for those 2 weeks. And then I will come to Dublin on the 14th and 16th of June. So it is a very, very, very tiring and unusually difficult time, but I'm looking forward to making sure that I give my all to make sure that you all pass the exam. Yes, Paulina, it will be busy, unfortunately. I There's no way around it, unfortunately, this time. I only ever do one course for each exam. The number of candidates has increased exponentially this time round, and that's just the way it is. I am going to bring a lot of extra equipment this time, okay? A lot of extra equipment. So don't worry about that. Normally I cater to about 35 to 40 each time I come, but I'm going to cater to about, I don't know how many, I think it'll be about 50 or 60. So I'll have that much equipment that will cater to that many people. So there'll be plenty of equipment and stuff to use as well. And just don't worry, just trust me. I've done this many times before, and I know how to successfully navigate all of you through this exam. Okay. I wish you the very best of luck. For those that I see again, I will do my best to make sure that you will pass this exam. I promise you. Okay? For those that are not with me, then I wish you the best either way. Okay. I pray for the best outcome for each and every one of you, whether you're doing the exam now in June or whether you're doing it later in the year. Okay. But now I'm going to love you and I will leave you, but I will be in touch with particularly the ones obviously that are coming on my course. There's a large number of you, and I will see you all very soon. Okay, take care, stay safe, keep practicing. Okay, don't stop, don't be distracted. Okay, and I pray for all of you. Okay, see you soon.